dead keratin. So acoustic feedback is when a hearing aid amplifies sounds into your ear, inevitably some of that sound is going to escape. If too much of that sound escapes, it re-enters the hearing aid microphone, which means the hearing aid re-amplifies that sound that it's already amplified. And then you can guess what happens next. That re-amplified sound enters the ear, it escapes back out of the ear, and it enters the microphone again. And before you know it, we've got a feedback loop. So the hearing aid's constantly re-amplifying sound that it's already amplified. And that causes the hearing aid to squeal and feedback. You can compare it to if you're having a karaoke and someone's too close to the speaker, you get that feedback then as well. It's very similar in nature. And of course, when you've got earwax or any sort of blockage in the ears, in this case, this patient hasn't got earwax, it's dead keratin that hasn't migrated. The sound hits the keratin, it reflects back out. And even if you've got a really tightly fitted ear mould that traps the majority of the sound in, inevitably when you open and close your jaw, your ear canal widens and it allows some sound to escape. So we've got the occlusion out, we've got the blockage out, but you can see there's all this dead keratin coating the canal wall. What is most concerning me at this stage is if you look at the posterior superior quadrant, where I am now with the suction probe, so that's called the posterior superior quadrant. So in terms of a compass, you're looking at the northeast. Whenever you've got dead skin there, which is what the patient's got, you've always got to be cautious that the patient may have a cholesteatoma. And that's because that region of the eardrum, so in the case of the left ear, the northeast, so the posterior means the back and superior means the top quadrant, that part of the eardrum is, if the eardrum gets sucked in, it's going to most likely get sucked in that region, and it creates a pocket. Now, if you've been watching my videos, some recent ones about cholesteatomas, I've explained it in depth, but I will summarise it very quickly for anyone who's not watched those previous videos. The ear canal and the outermost layer of the eardrum is lined of a very thin layer of skin, an epithelial layer, so it's an outer part of the skin. So you get the epithelial, you get the dermis, so this is just the outer layer of skin. And it's really, really thin, and as that skin dies and sheds, it moves sideways, it migrates out of the ear, almost like a conveyor belt motion. So the ear canal's full of skin, it dies and it sheds, it moves sideways, and you have another layer of skin growing underneath, and that dies and that moves out sideways. So the ear is self-cleansing, the skin naturally comes out by itself, or it should. Now, when you've got a pocket, so when the eardrum is sucked in, there's a little cave there, and the skin, as it's migrating, it migrates into the pocket and it gets trapped. And if that skin is trapped and it doesn't migrate, that plug of skin is going to get bigger and bigger, and it's going to get infected. And that's what we call a cholesteatoma. And cholesteatomas can be very, very dangerous because these infected skin plugs can grow inwards into the middle ear. It can cause damage to the facial nerve, the organ of hearing, the organ of balance. It can erode all the ossicles, the three bones, the malleus, incus and stapes, otherwise known as the hammer, anvil and stirrup. It can then go upwards towards the brain. It can infect the layer, the meninges layer, which surrounds the underneath of your brain. And worst case scenarios, it can cause a brain abscess. A cholesteatoma is highly, highly dangerous if it's untreated. And because we can see this skin here, I don't know if there's a retraction pocket. All I can see is a layer of dead skin. So what I'm doing first, I'm just clearing everything else out, and now I believe I'm going to approach this area because I want to peel this away if possible. Now this can be obviously very, very uncomfortable for the patient, but we're just being really gentle, and you can see slow, almost gentle brushstrokes motion. I'm just kissing the surface. I'm using a fine end gauge suction probe, so it's a lot quieter than a standard Zollner suction probe. It's less traumatic, so if we do apply a bit too much pressure, it's less likely to do damage than a standard Zollner suction probe. You can see I'm just peeling away. So far, so good. I can't see a retraction pocket, so I'm pleased. So this layer of skin, it's not trapped in a little pocket. Instead, it's just coating the eardrum, which is, we can still remove it, but fortunately, I'm really pleased that there's nothing behind this that's sinister. And you'll just watch me now continue just peeling away the skin. And there's and you'll see in a moment, you may not be able to see it, but on the right hand side of the eardrum, so the back part, the posterior part, there's actually a dead layer of skin there. And it's just a fresh layer of skin. You can see me peeling it away now. And this is how our eardrum normally is. You got an undercoat of a fresh layer of skin, and the older skin is pushed outwards, away from the fresher layer, and that skin normally should just migrate outwards. If you think about, if you've got a pond and you've got a pebble and you drop the pebble in the middle of the pond, you'll get the ripple effect. And think about those ripples, almost like the skin in your eardrum, dying and shedding and moving sideways and out of the ear canal. On average, the skin migration, the epithelial migration of skin in the ear is approximately, it does vary individual to individual, 3 millimeters a month. If you average out the ear canal to be 3 centimeters, so it takes roughly 10 months for a piece of skin on the center of the eardrum to die, shed and migrate out of the ear. Now, why is this skin not migrating in this patient's ear? And sometimes patients just have, for some unknown reason, that mechanism for the skin to die and shed and migrate, it's seized, it's halted, it no longer operates. It's well documented as well. Patients who undergo radiotherapy around the ears, that can also stop the skin migration. And this skin plug also, if we didn't treat it, it would eventually form a keratosis obturans. So you could actually call this case a pre-keratosis obturans. It's not, one of the hallmarks of keratosis obturans is actually that skin plug. It can cause pain. This patient wasn't experiencing any pain, so you could argue that it's not a keratosis obturans for that particular reason, for the true definition of a keratosis obturans. But I suspect if it was left as it was, it would eventually cause a lot of pain for the patient. Now, we're not going to get every little last speck out. It's just impossible. It's going to be very uncomfortable. There's a bit of a widening there as well, as you see, and that is a hallmark of keratosis obturans, a bit of a widening of the ear canal, but it's probably pre or grade 1 keratosis obturans. And as I said, for me, the main thing was that there's no retraction pocket at the top right-hand corner of the eardrum, no evidence of the cholesteatoma formation. We're just not going to get all this skin out. That's just unfortunate. This is this patient's ear. This is their ear. There's no real treatment per se, and they just need regular cleaning. And you're just going to again get this dead skin flakes that's just not going to migrate out of the ear. Otherwise, it's a nice healthy eardrum. Got a slight tympanosclerotic patch on the left-hand side. That's the skin plug. You can see it's almost white in appearance, very mushy in consistency, very bouncy.